Good morning, everyone. Thanks for joining us. We'll get started in just a minute. Good morning, everyone. Thank you for joining us on our fifth seminar of fall 2021, our Implementation Science Seminar Series. I'm Ronnie Elwey, and I am the Director of the Implementation Science Core in the Brown Department of Psychiatry and Human Behavior at the Alpert Medical School at Brown University. I'm really excited today to introduce Dr. Hannah Frank as our speaker. Dr. Hannah Frank is currently an NIMH T32 postdoctoral fellow in child mental health in the Department of Psychiatry and Human Behavior at Brown. She completed her PhD in clinical psychology at Temple University. She's the principal investigator, or she was the principal investigator of an NIH F31 grant examining dissemination of exposure-based treatment for anxiety through experiential training for community therapists. And you'll hear more about education and training strategies from her today. Dr. Frank has served as a co-investigator and collaborator on several other NIMH, NICHD, PCORI, and SAMHSA grants. Dr. Frank was recently elected to the board of directors for the Society for Implementation Research Collaboration, which is the only professional society in the United States focused on implementation science. I am thrilled to announce that starting in May 2022, Dr. Frank will begin her tenure as a faculty member in the Department of Psychiatry and Human Behavior, and will be working as faculty in our Implementation Science Core. Thank you, Dr. Frank, for presenting at our Implementation Science Seminar Series.
Thank you so much, Ronnie. And thank you all so much for attending this talk. I'm really excited to be talking about educational implementation strategies. This is an area that I'm really interested in. So as we go, feel free to put any questions in the chat, and I can answer those at the end. So before I get into the details of my talk, I want to provide a brief overview of some implementation science terms for those of you who might be less familiar. I'll borrow Jeffrey Curran's language of the thing, which is one of my favorite teaching tools for explaining implementation science. So the thing is the intervention, practice, or innovation of focus. And so in this talk, you will hear me talk some about exposure therapy as the thing, as well as a variety of other evidence-based interventions. And efficacy and effectiveness research is whether the thing works, which is typically examined in tightly controlled RCTs, and outcomes focus on patient outcomes like symptom improvement. And then implementation research is how we can help people and places do the thing. And so this is where outcomes focus instead on things like feasibility, acceptability, and adoption. And then finally, and relevant to what I'm talking about today, are implementation strategies, which are methods or techniques that are used to help people do the thing. And so Byron Powell and colleagues created a list of 73 implementation strategies, which you might hear referred to as ERIC strategies, and they encompass a wide variety of domains, from things like making billing easier to using mass media. And today, what I'm going to talk about is the subset of implementation strategies that specifically focus on education and training. So in most implementation studies, and really in effectiveness and efficacy studies as well, educational strategies are the first step. So in other words, there's pretty much always some type of initial training or education that occurs at the start of a study. And so we do know that most education does lead to relatively small changes, so less than 10% absolute change in outcomes like adherence or skill. But these changes, these small changes, really might have clinical relevance, especially on a large scale. And in most implementation studies, educational implementation strategies are just one component, but they should really be designed thoughtfully to maximize outcomes. And so ideally, we talk a lot about providing evidence-based interventions. We should also provide evidence-based professional education. And we know from adult learning theory that adults are generally motivated to learn, can direct their learning processes, and they prefer to learn through problems that they encounter in their daily work. So first, I'm going to talk through the most common types of educational implementation strategies, which again are typically combined with other implementation strategies. So this summary is based on a review of educational implementation strategies by Wensing in the book Improving Patient Care. And they describe these 6 strategies, which I'll briefly talk through. So the first one is educational material. So this is the idea of any kind of publication, mailing, written recommendations for clinical care. It could be through journals, media broadcasts, listservs, and it tends to have a relatively small effect on learning outcomes, and it's a really important way of disseminating information. The next category is large educational meetings. And so this is when care providers participate in things like conferences and lectures, and it's usually larger groups, so more than 25 people. And this is when information is presented orally, visually, and it comes with the assumption that people are coming, they want to use the information in their job. And so this is much like today's talk, right? So this includes things like lectures, seminars, courses, conferences, and because of practical considerations, having a larger group, these types of strategies tend to be more didactic and passive, but again, can reach a broader number of people. And the research shows that this tends to have a moderately positive impact on performance, especially if it includes an interactive component or multiple sessions. The next category is small-scale education meetings. And so this is, again, participation of care providers in workshops, skills training, educational groups, quality circles, or peer review groups. And these can have a range of functions and formats and purposes. So this could be focused on technical or communication skills. It could be continuing education in small groups, also supervision groups, quality circles, practice-based learning. And this is often combined with other implementation strategies like feedback. And once again, this tends to have a moderately positive impact on professional performance, and not surprisingly, perhaps, tends to be more effective than large-scale meetings because they are generally more interactive, engaging, and responsive to participants' learning styles and needs. Then outreach visits take place in the practice setting of care providers with somebody who provides training, usually an expert who provides some sort of training, instruction, or support. This could be a nurse, a physician, a pharmacist, another health professional who comes, provides explanations about the specific practice. And it's often used for things like with physicians, changing prescribing behavior, but is really relevant anytime you're trying to change a provider's behavior. And this has been studied less frequently. Some studies do indicate positive findings, others don't find an effect. And notably, it's also a really more expensive approach. E-learning is also relevant to today. This involves anything online, using the internet, other technologies, and growing evidence suggests it's equal to face-to-face learning. And then finally, opinion leaders, which I'll talk more about later when I talk about determinants. But this is when somebody who is seen by colleagues as being really committed to clinical improvements or being recognized as a clinical authority or a role model might play a role in training. So maybe they sign off on educational materials, maybe they deliver or co-lead a lecture, maybe they conduct outreach visits. And again, this tends to have a moderately positive effect. So this slide is just a summary of everything that I just talked about, so you can see it all in one place. And this is again, one way of categorizing different educational implementation strategies and thinking about what do I even mean when I say that? This is sort of your initial quick overview. And as you see here, today is really that large-scale educational meeting, and it tends to be more effective when there's an interactive component. And of course, being a webinar, it's not going to be the most interactive, but in the interest of being more interactive, I want to present a poll to briefly test your understanding of the strategies we just talked about. So peer consultation is an activity that takes place for clinical activities when people meet in a group, provide input on each other's cases. And so if everyone can go ahead and try and complete this poll, my fingers are crossed that technology agrees with us. You can either go to pollev.com/HannahFrank108, which it says at the top, or you can just send a text message to 22333 with Hannah Frank 108. Either way, indicate your answer. What kind of educational implementation strategy do you think peer consultation is? So this would be group peer consultation. Got some votes for opinion leader. Any other? I'll give people a moment to take some more guesses about which of those 6 strategies they think it is. Gotta guess. Oh, we got some more votes coming in. I love seeing these numbers move. I hope that you're all able to see the numbers move on the poll as well. Oops. All right, we're refreshing. There we go. Okay, so it's looking like it was tied for a moment, but it's looking like right now we are landing on a winning most popular answer, which is small scale educational meetings. So that is the most correct answer, given that peer consultation tends to take place in relatively small groups and is typically interactive, involves active learning, it's consistent with adult learning theory. And one of the ways in which it's consistent is that it generally involves things that are encountered in people's daily work. So I'm sure there are definitely ways, I see that other answers of outreach visit and opinion leaders, that those things could be relevant. Outreach visit could be relevant if it's more of an expert consultation. Opinion leaders could certainly be relevant in peer consultation. So I also love that answer, especially if peer consultation is, say, led by a particular peer who is an opinion leader, who is seen as somebody who other people look toward for their authority, their opinions. So I assigned one correct answer, but I love these other ones as well. So thank you for indulging me, and I'm so glad our poll worked. It's always a gamble with this stuff. All right, so now that we've talked about some broad categories of educational implementation strategies, I want to delve a bit more into the specifics of training interventions that are most effective for training therapists in evidence-based mental health interventions. So this is a systematic review that I conducted with my colleague, Dr. Emily Becker-Hames, and my graduate advisor, Dr. Phil Kendall, where we specifically examined outcomes for a variety of training approaches used to train mental health providers. And again, although the focus here is on mental health outcome or mental health providers, the findings are probably applicable to broader frontline providers. But I will, again, this is focused specifically on licensed providers. So before I get into the results of my review, I want to highlight just a few things we knew coming into our review, which was published in 2020. There had been actually 3 other systematic reviews on this topic published in 2010. And so results from those studies suggested that reading a treatment manual alone does not result in changes to therapist skill or confidence in an intervention. And similarly, just attending a workshop is not enough to improve therapist skill, increase their use of interventions, or improve their client outcomes. There was, from those previous reviews, some evidence that active learning strategies, so this is things like behavioral role plays and case discussion, did increase knowledge and skill, and that using skill rehearsal and feedback further extends and can deepen learning. And expert consultation were highlighted as strategies that increase the use of interventions in practice. And finally, these previous reviews showed that trainings that had more components, so they had training, they had consultation, maybe they had booster training, training for supervisors, more components led to better outcomes compared to training approaches with only one component. Probably not surprising, it's sort of more is better in that case. But in our review, we wanted to look at therapist training since those 3 reviews in 2010. And there were quite a few studies, there were 76 studies published since 2010 of, again, licensed mental health clinicians and they're following training in evidence-based interventions for mental health. So we categorized our training approaches into 5 categories. They included workshops alone, workshops followed by expert consultation, online training, train the trainer models in which expert therapists provide training to select therapists who then train other therapists. And then intensive training, which is when there were more than 20 hours of training plus 2 or more other training components. So this is a diagram that provides a rough overview of our findings. And so it's not based on precise statistical results, but more of a way of demonstrating that there's this trade-off between efficiency and effectiveness of training approaches. So first I want to highlight workshops alone. So what we found was that there are certainly benefits to these lower intensity training approaches, even if they're relatively lower, have lower effectiveness. And so, for example, having workshops alone might provide broad dissemination of information. And this might motivate clinicians to learn more about the intervention, seek out additional training. And so these workshop alone studies tended to be things like a half day or a full day workshop, where it was a didactic training. People went, they sat in a room with other clinicians, they learned about it. And this does improve clinician knowledge. So for example, if somebody goes to a half-day workshop on suicide risk assessment, if they take a quiz afterward on suicide risk assessment, they will know more than they did before. But there's not a lot of evidence that that actually changes clinician behavior or use of something, again, like suicide risk assessment. And in contrast, if we look at this other end of things, the intensive training, not very efficient, but highly effective. And this is something that's quite likely to lead to improvements in therapist knowledge, intervention use, and competence as rated by observers. But again, this is resource and cost intensive. So when we're thinking about implementation, this is 20 to 80 hours of training by experts. It also includes other components like expert consultation, videotape review, and even written feedback on videotaped therapy sessions, and things like learning collaboratives. So this kind of fits with the previous findings of more might be better. And there's some other promising in-between versions. So train the trainer is something I alluded to before. It's sometimes also called that cascading model. And this is, again, where you have experts train an initial cohort of clinicians, and those clinicians usually also learn about how to train other people. And then they are tasked with training other clinicians in their agency. So this can help with turnover because you have a lot of people in the agency who can continue training each other. And it's more efficient because it requires less expert time. And so results from this, certainly the outcomes are not as positive as the intensive training, but it has been shown to improve competence after training, not quite as high as expert-led training, but certainly a meaningful difference. And then finally, this sort of middle area is workshops that include follow-up expert consultation. And these have been shown to be more effective than workshops alone. And we know that more participation in consultation tends to lead to better outcomes. And online training that involves the same thing, so online training really with consultation, tends to be consistent or equivalent with in-person trainings and somewhat more efficient given the lack of travel time. So overall, there are definitely trade-offs for each of these. And so hopefully this depicts the ways, the things to consider when thinking about what training approach to use. So in terms of key findings from this review, so as I said, there's still limited, just like previous studies, limited support for low intensity training. So one-time in-person or online training will increase knowledge. It maybe will even increase interest in a certain intervention, and maybe therapists then are motivated to seek out additional training, but it probably won't change behavior and actually lead the clinician to implement what they learned about. The second key finding was that we confirmed prior findings that ongoing consultation can yield better outcomes. And so, and this again is also true with online training, where consultation after online training is just as important and effective as for in-person training. So consultation really seems to be key. And there's a lot of interesting work happening too, in terms of thinking about what are the best strategies for consultation. So again, each of these you can dive in a little deeper and think about, even for consultation, what are the strategies or what are the approaches that work best to maximize the effectiveness of consultation. Train the trainer, again, is a promising, cost-effective, efficient model. And more work is needed to determine whether, so I talked about how therapist competence is rated as usually adequate, at least adequate after train the trainer training. And there's not really a lot of research on patient outcomes. So there's this question with train the trainer training of whether that sort of dilutes the patient outcomes or the training effects, and more work is needed on that. But it is definitely a promising model. And again, intensive trainings do tend to increase therapist competence in intervention use. And we do not yet know, though, what are the active ingredients of these interventions. So I've talked a few times now about this idea of more being better. And there's a likelihood that there are certain more active ingredients of training, and that's something that needs more research. And then finally, results from this review highlights that there's still a lot that we don't know about how to best train therapists to deliver interventions. So a lot of the studies that were included in this review had critical methodological limitations. So this included things like measurement, what they use for outcome measures, brief periods of follow-up of assessments after training, not a lot of comparison conditions, and again, lack of observer ratings of key outcomes like competence and skill and intervention use. So this points to directions for continued research. And another key thing that is needed is longer term follow-up, because even with these most effective models like intensive training, it's not entirely clear how sustainable or cost effective these things are. And given the fiscal realities of the mental health landscape, this is a really important area to continue to consider both cost and sustainability. So another conclusion that came out of this is that even though therapists use a lot of evidence-based strategies, or our goal is to get therapists to use a lot of evidence-based strategies to support client behavior change, not a lot of studies have thought about using learning theory, using our behavior change principles to guide training, even though it logically makes sense that if these principles work to change client behavior, that they would also work to change clinician behavior. So this led me to think about, what if we apply the behavioral principles of exposure therapy for anxiety disorders, which is the intervention that, as I said, is a focus of a lot of my research, to clinician training, because we know that therapist anxiety is often a barrier to using new interventions. So for those of you who aren't familiar, exposure is this key active ingredient in treatments for anxiety disorders, OCD, and trauma. And what it focuses on is having people gradually approach what they're afraid of in a supported way. And research shows that in CBT for anxiety, more exposure leads to better treatment outcomes. And this supports the idea that gradually facing scary things could make those things easier. So all of this made me to think, how could we apply exposure therapy principles to enhance therapist training? So I conducted a study that examined experiential training to teach therapists about exposure therapy. And the main focus of this study was really on assessing the feasibility and acceptability of using experiential training to teach clinicians about exposure therapy. And as this title suggests, the experiential training involved having therapists themselves complete exposures using a brief one-session exposure therapy treatment protocol for spider phobias. So as I said before, exposure is really a critical ingredient in treating anxiety. And we know that a huge barrier to clinician adoption, especially of exposure therapy, is fear on clinicians' part about using exposures. They worry that it'll harm their clients, that clients will leave treatment, that something horrible will happen. And so having heard this from many clinicians who I worked with in community settings, I thought it seems like a really logical step to address this fear by using the exact behavior change principles we already know work to reduce fear, which is exposure. So specifically, we had therapists who were working in routine clinical care settings, randomized to either training as usual, in which they did, so actually people in both conditions had more didactic training in the first half of the day. And in the second half of the day, training as usual, they did role plays, they talked about case examples, they viewed video clips of exposure. And those who were randomized to the experiential training completed an entire exposure protocol in the second half of the day. So they were paired with another participant, and they had the opportunity to serve as both the therapist and the client throughout the day. So this meant they had to guide their partner through exposure and complete their own exposure related to spiders. And this included things from pictures and videos all the way up to holding live tarantulas if they were willing to do so. And all of this was with the goal of allowing therapists to address their own fears, both that come from asking someone else to do challenging exposures and to experience exposures from a client's perspective. So we collected measures at pre-training, post-training, and follow-up, and all participants attended consultation calls weekly for 3 months after training. And then we collected qualitative interviews at 3-month follow-up from clinicians who were in the experiential group. So preliminary results, and again, this is a pilot study with a relatively small sample, but it suggests some promise for experiential training having an impact on a key implementation outcome of interest, use of the intervention. So specifically, we found that there was a significantly greater change in exposure use over time in that first 1 month for the experiential group compared to the training as usual group. And this corresponded to a pretty large effect size. We also found really strong evidence for feasibility and acceptability. Quantitative measures of acceptability had high scores, and the qualitative responses supported this further. And one theme that I wanted to really highlight from the qualitative interviews was a grounded theory theme that emerged about parallel process. Therapists consistently said that the parallel process of experiencing what the client experiences during exposure was one of the most effective aspects of training. And so actually we even found with our mixed methods analyses that clinicians who were less fearful of spiders felt like they missed out on the full training experience and actually wanted more exposure. They wished they'd gotten to complete exposures that evoked fear. And so I think that this quote provides a nice summary of what a lot of therapists got out of the training. And again, it's this idea of that parallel process, having that deeper level of learning of doing it yourself. And this highlights that future work should continue to examine the effectiveness of this approach on changing behavior, and specifically to think about what is the mechanism of change being engaged here. So on one hand, clinicians might experience exposure as being less scary because the outcomes they feared didn't come to fruition. And that might be because the training reduces their own anxiety. And it's also possible that receiving exposure made them more comfortable delivering it, using it, and both receiving exposure and delivering exposure to their partner may have also increased self-efficacy, right? So there are a couple of potential mechanisms at play here, a big one being clinician anxiety, another one being self-efficacy. So one thing that was really exciting for me is that when I came back to Brown for my internship and then for postdoc, I got to collaborate with my colleague Josh Kemp at the Pediatric Anxiety Research Center at Bradley Hospital on his NIMH-funded project called STRIVE that actually looks at this exact question about mechanisms underlying experiential training. And so this STRIVE study is using an experimental therapeutics approach to assess experiential training. And specifically, Dr. Kemp's study is focused on assessing whether experiential training leads to changes in therapists' negative beliefs or clinician anxiety about exposure. That's the putative mechanism. And the study is comparing whether didactic training versus experiential training is more effective at changing clinician anxiety or clinician beliefs about exposure. So in this study, it involves the experiential training involves self-exposures and partner-led exposures that follow this exposure to exposure approach consistent with what I tested in the study that I just described. And so there are two phases to the STRIVE study. The first one was a case series analysis that just included 6 therapists who all completed the experiential training. And that was used again with this experimental therapeutics approach. The idea there was to establish appropriate dosing. How many experiential tasks did therapists need to do to achieve a change in the target, which was, again, therapists' negative beliefs about exposure? So once that was identified, this dose that was needed of number of experiential tasks, this led to the second phase of the study, which is a randomized trial that's comparing didactic training, which is basically training as usual, to experiential training. And so as part of this, therapists completed a 12-hour workshop training, and throughout that, their beliefs or and anxiety about exposure were assessed. And then after training, therapists refer 2 clients to the study who they plan to use exposure with. And then their use of exposure is audio and video recorded and coded using a microanalytic coding system. So we can also assess quality of exposure delivery. So again, the goal of this is to understand, does experiential training lead to lower negative beliefs in the experiential training group? And are those negative beliefs related to higher quality exposure delivery? So all of this will provide more insight into the mechanisms of a particular educational implementation strategy, which is experiential training. And it's also using other educational implementation strategies because, like I said, they're often used in combination with each other. And these strategies include small scale educational workshop, like I talked about at the beginning, as well as weekly expert consultation. So another direction that I've been taking this work, in addition to thinking about mechanisms of educational implementation strategies, is how can we expand the principles underlying this exposure-based experiential training to other interventions? So I've been working with my colleague, Dr. Emily Becker-Hames, who I mentioned before, she's at Penn, and we've been considering the role of clinicians' own anxious reactions to delivering certain evidence-based interventions, including and beyond exposure. So we have been thinking about how certain evidence-based interventions might act as a negatively valent stimuli for clinicians. So in other words, clinicians might hear about, learn about, read about certain evidence-based interventions and have this reaction that it seems like a scary intervention to do, that it makes them anxious to think about doing that. And then that in turn might lead them to avoid or suboptimally deliver evidence-based interventions. So for exposure, for example, suboptimal delivery of an intervention might look like, rather than having clients approach the things they're afraid of, suggesting either the client does something really, really easy that they're not even afraid of, distracting clients completely during an exposure so they're not really encountering it, or again, completely avoiding exposure. So this is a well-documented phenomenon in exposure therapy where we know that the idea of doing exposures makes a lot of clinicians anxious, and as a result, they avoid the intervention. So there are some other evidence-based interventions that have a major research to practice gap that might also have this same phenomenon happening as a barrier to using the intervention. So we've talked about exposure therapy. Another common one might be suicide screening, assessment, and brief interventions for individuals at risk for suicide. That's another intervention that might be negatively valent for clinicians. And as a result, it brings up this maladaptive anxiety and avoidance on the part of clinicians, stopping them from using an intervention that we know can be effective. Another example of this is the use of timeout for pediatric disruptive behavior disorders. So our suggestion here and our thought is that attending directly to clinicians' anxiety about delivering these challenging interventions might actually improve their implementation. And specifically, experiential training might be one avenue to do that. And there are probably a lot of other novel educational implementation strategies that could address this need. But the idea of attending to the therapist's own experience of what it's like to deliver an intervention is something that hasn't been given a lot of attention. And yet we very clearly see from exposure-focused work that it's a major barrier to implementation. So this is where I'm hoping you can all brainstorm and use your creativity. I'm curious what people think. And again, this is also in the name of being interactive, making sure people are as engaged as possible. What are some other interventions, and they don't have to be mental health interventions, any kind of interventions that might benefit from this type of experiential approach to training, in which, again, clinicians are prompted to either gradually face delivering the intervention, so to do it in small steps, or maybe they undergo some aspect of the intervention themselves. Yes, eating disorder treatment. Thank you. And again, instructions are the same. If you weren't here for the earlier one at the top, pollev.com/HannahFrank108, or you can text HannahFrank108 to that number. Yeah, so eating disorder treatment was one definitely that causes clinician anxiety. Ooh, there. I wonder if I can make these smaller. No, I love these. Oh, here, I can scroll. Okay. A second eating disorder one, yes. And especially eating disorders for exposure for eating disorders too is another one. We have a couple for substance use treatment. I'm really curious to hear more about that one. To be honest, it's not in my area of expertise, so I'm so curious how what kind of anxiety on clinicians' part comes up around that. And then I also prescribing prep, absolutely. And probably like conversations around that as well. Measurement-based care, yes. Screening for substance use, yes. I think any of those questions that involve, suicide assessment, substance use, anything that involves asking questions where either there's fear about how the person answers, right? Like, what if the person says, yes, I'm using substances, or yes, I'm feeling suicidal. So it's the fear about the answers and the fear about, if I ask the question, will that cause something? Yes, discussing weight management. And that's when again, the eating disorder one, totally agree with that. Any of these topics that bring up those fears from clinicians of what will the person think if I ask that? What will the outcome be? Will they leave? Yes, sexual assault, other kinds of traumas as well. Race-based trauma, absolutely. Interpersonal violence and safety. Yes, all of these topics that are really important for our clinical interventions and yet can be really challenging and scary as a clinician to talk about, ask about, provide information about. And this is where those questions, I love these answers, keep them coming in, thank you. I think one of the things here is this idea of those two functions I talked about, where it's both that clinician anxiety about asking about these things, talking about sexual health, screening for things like substance abuse or suicidality, talking about issues related to race-based trauma and racism, talking about trauma history, sexual assault, any of these things that are challenging, clinicians feel anxious about asking about. And there's the self-efficacy piece too, right? Of how do I actually do it? What do I do next if I ask the question? Novel technologies in patient care, yes, I love that. I'm hoping that these answers are all saved because I am really so grateful for all of these inputs and ideas. So many of them are ones that I hadn't explicitly thought about. The sexuality, gender identity is another great one as well. So thank you, everyone. I could keep talking about this for a while, and I am so grateful for all these really interesting answers. If anyone wants to have conversations offline about any of this too, I would love to hear more, especially since some of these are totally outside of my area. I'd love to talk more about ways we could apply this. So thank you. I will continue on, but again, happy to discuss more if anyone would like to. And because before I wrap up, I just want to briefly talk about some of the determinants that relate to outcomes from educational implementation strategies. So in implementation science, when we talk about determinants, we're really just talking about what are the things that that determine or that predict how effective education effectiveness might be. And so I want to just highlight a few things that we know can affect how well your educational implementation strategy works. So the first one is a needs assessment. So before we provide any kind of training, we want to assess the group who is receiving training and the setting. So this might mean assessing the content, so which topics. It might be many of those topics that you all just mentioned in that previous poll. It might be about the format, so the fit with the preferences, learning styles, and logistics of a setting, and the needs of the group to guide tailoring. And this is all thinking about if you're at the start of a study, this might be as part of your pre-implementation phase, identifying, we know that educational content is, that learning is higher when educational content is perceived to be relevant and when there are explicit goals that have been articulated. And so when we know the content, when we assess things like, what are clinicians' emotions around this, right? Like, so if we are suggesting something like in those previous slides that you all mentioned, if we're saying we need to screen for suicidality, we need to talk about prescribing prep, we need to talk about, doing trauma-informed care, we might also need to do a needs assessment of what are people's current perceptions of this, or maybe it's asking about, gender identity or sexual orientation. We need to understand what is people's existing knowledge and what are the things that we need to be targeting and changing. So a second determinant is active participation. So as I noted before, active participation generally leads to better training outcomes. And this might involve things like the polls, like having people answer questions live if it's a larger group. In smaller groups, it might involve things like the dreaded role plays, which I know that people often have negative reactions in a training to doing role plays. And yet we know that doing role plays leads to more positive outcomes. It might involve things like interteaching as well, where they're group discussion or their discussion topics that are led by the small groups or that are discussed by the small groups. And overall, what we know is that active participation may increase motivation and provide the opportunity to focus on personal learning needs. And this is where you can also get at understanding those individual level determinants and those individual level attitudes, learning styles, things that can make learning and education more effective. We also know that overall, a mix of lectures and interactive sessions is associated with higher effect sizes than for small scale educational meetings. So if we just have lectures alone, or even if we just have interactive sessions alone without lectures, neither of those is as effective as the mix. So that's why for the study that I talked about earlier with the tarantula training, that's why I had half of the day be that more didactic lecture. There were chances for some interactive activities. We had things like, we had raffle tickets so that each time somebody asked a question, they got a raffle ticket, and then every once in a while we drew a ticket and gave a small prize. So we tried to keep it somewhat interactive, but it was largely passive and didactic. And then the second half of the day was that truly interactive, either doing exposures with spiders or doing role plays, watching videos, having discussions. So that mix is really the best approach. Another determinant is the duration of the educational activity. So on one hand, and as I alluded to with my systematic review findings, more time might be better. So if we have continuing education workshops that are less than a day, that tends to be less effective than several days of training. However, there are likely to be diminishing returns after a certain point, especially for busy clinicians, and also just for consolidation of learning. So there's one review that reported little difference between 2 days of training and longer. It also does depend on, again, the spacing of the training, the content and approach of the training. The intensive trainings that I described in my systematic review tended to be somewhere between 20 to 40 hours in a block at the most, and several of them had training spaced out over time or had one block of training followed by 6 months of consultation or practice, and then another block of training. So thinking not just about duration of education, but also the spacing. And then another consideration is, as I talked about before, the role of opinion leaders, where including opinion leaders may improve the effectiveness of training. And there are a lot of different ways to do this. One example of this is Dr. Shannon Dorsey at the University of Washington does the CBT Plus program for Washington State. And she does trainings throughout the state, and she has an opinion leader involved in every training. And so that is actually somebody who's previously attended one of her trainings, who works in a community mental health clinic, who co-leads the trainings with her. And that makes a really big difference in terms of getting the buy-in, in terms of that person's coworkers and colleagues seeing this is something they bought into, that they use in this setting, and that they understand how this intervention can be used in that setting and are still saying this can work. So that's just one example, but there are a lot of ways of integrating opinion leaders that can be really effective. And then finally, assessment and feedback. And so this is something just in terms of keeping in mind the role of doing assessments throughout training and also getting feedback from people and tailoring it then to the needs of the clinicians who are in the training. And ideally, if you have time, adjusting it accordingly. All right, so I'm wrapping up just when I wanted to, which is always a nice surprise. So overall, most types of educational implementation strategies have a relatively small effect size, but these changes are clinically relevant. And again, just remembering on a large scale in terms of number of patients seen, reducing costs, improving effectiveness and efficiency of healthcare, and again, pretty much every implementation study or even effectiveness or efficacy study involves some kind of training. So maximizing our training approaches is really important for improving our overall outcomes. Overall, more active, more personalized training tends to be more effective in changing behavior. And written material alone, although it's not as effective, it does increase knowledge. So there are just different functions that they serve. I want to be clear that saying written material or a workshop alone, although they don't change clinician behavior per se, increasing knowledge of something is also really important. So for example, I'm not going to expect that a primary care physician is going to deliver exposure therapy. I don't need them to attend a lengthy training on how exactly to implement exposure therapy. But if they have written materials or if they have a better understanding, maybe from a half-day workshop of what it is, what it's all about, that they understand it's not something that's really scary or harmful, and in fact, it's the best practice for treating anxiety and OCD, that's really powerful. That might mean that a lot more kids or adults get referred then to do exposure therapy and get a treatment for anxiety that we know works. Another just final point, there are many opportunities to enhance training with technology that are just starting to be examined, like virtual reality-based training. I know someone on the poll mentioned the use of novel technologies, which of course have their own implementation challenges, but just thinking about ways that we can really enhance training and integrate technology into doing that, to use online methods, which are way more efficient for training for a lot of clinicians. These are things that are a really exciting next step and next direction for training. And then finally, as I've said repeatedly now, educational strategies likely need to be combined with other implementation strategies to lead to meaningful change. But just because educational strategies may not be your most active ingredient in a large implementation study, really putting the time and effort and consideration into designing your educational implementation strategies thoughtfully can really make a big difference in the long run. So I have my references, which I know you can't see, but the slides will be posted if you do want to look at those. And I will now open it up for any questions.
Hannah, thank you so much for that terrific talk. I am always so impressed that every time I hear you talk about these studies that I learn something new, even though I've heard you talk about them again. And obviously, as someone who probably could benefit from some exposure to spider training, I always really appreciate this. So you touched on this a little bit, and I am just going to wait for some other questions to come up in the chat, but I was thinking, you mentioned mechanisms during your talk, and I know you've been very involved in I don't know if is it an R25, R18?
R13, yeah.
R13 project that Kara Lewis is leading to look at mechanisms. And you mentioned also at the end, that it's also important to increase knowledge and awareness, which is, people often think that knowledge and awareness doesn't change behavior because, a lot of our health behavior theories have shown that, but you've pointed out that that's an important mechanism. Can you say something more about some of the other mechanisms, and perhaps that's why a multifaceted educational training works well, because you are getting at these, like, what do you think is happening as you're doing these multi-component trainings?
Yeah, so I think, like I said, clinician anxiety is the one, or negative beliefs, that we're really focusing on this. And I talked about self-efficacy being another one. And I actually think that things like knowledge, attitudes is a really big one. These have a big impact, and this kind of relates to that point I made at the end about like primary care physicians, for example. If training shifts attitudes about something, and then, if these are people who are then like talking about about an intervention to other people, that might be another mechanism that's activated with training. It's just attitudes. And then that might change openness to learning about other interventions. So I think about training mechanisms, like common ones being things like knowledge, attitudes, self-efficacy, confidence, which is similar. Again, that anxiety, and those are some of the big ones. And I think then we combine it with other implementation strategies that are acting on other mechanisms, and we think about it, if we think about the context in which it's happening as well. And so if we think about in an organization, if we have multiple people attending a training and multiple people, if that training changes the attitudes of multiple people, then that might also change the attitudes overall at an organizational level over time as well. So I think those are some of the other ways that I would be thinking about mechanisms at that individual level that we think about also at an organizational level, of course. And that's why there are often recommendations to include, for example, supervisors from an organization in training, as well as clinicians, because of the need to shift some of these mechanisms at both an individual and organizational level.
That's a really good point about having different levels of people involved in that training to get at those different mechanisms. You're getting, a lot of kudos in the chat about, thank you, and that you really walked through this in a very approachable way. And a question is in the train the trainer model, how common are consultations? And if they occur, how frequently do they occur? This person is asking that they would like to make them as effective, would more, I guess, sorry, I'm reading it wrong. Would more, I guess, more frequent consultations make them as effective as opinion leaders and workshops?
Yeah, that's a great question. I mean, from an empirical standpoint, I'm not 100% sure, but what I would say is that one of the benefits of the train the trainer approaches, in addition to the efficiency of it, is that it does sort of integrate that opinion leader approach naturally, right? Because what's happening is you're seeing all of these people in your organization and these people whose opinions you respect and value are disseminating this information. And they're basically saying, I think this information is worthy of dissemination. So I think there's a really important point in that question, that another benefit of train the trainer is that it sort of integrates that opinion leader approach. I'm not sure, I think the idea with it is that you're moving away from the expert consultation and that it probably does involve peer consultation. I don't know of any studies off the top of my head that have done train the trainer plus expert consultation. And I would actually be really interested in seeing if adding expert consultation maybe augmented it. I'm actually not sure, but that's a really important question, maybe a question for future work.
A good way of having either head-to-head strategies or combinations of strategies being tested. Yes. Another question is, can you briefly speak to considerations such as the pros and cons of training advanced doctoral providers versus extant therapists versus school personnel versus lay people or opinion leaders, beyond feasibility and other concerns, just in terms of more teaching and learning more extensive evidence-based practices?
Yeah, that's a really interesting question. And I think the other category I would add to that too is also like master's level, training master's level clinicians. I've mentioned a couple of times, Dr. Emily Becker-Heems and I have collaborated on a lot of this work. And she and I have talked a lot about not just training advanced doctoral students or training doctoral students, but also master's level clinicians as well during graduate school, where there is variability in whether training involves evidence-based practices. So, I think the considerations are largely about at a programmatic level, if it's a doctoral program that's already training people in evidence-based interventions, you're less likely to have some of these considerations, not to say they're not relevant because they are, but they might be less likely to have some of the concerns about like clinician anxiety or attitudes about evidence-based practices if you're talking about training an advanced doctoral student who's in a program that's really focused on evidence-based interventions. That will be very different than training somebody who's in community mental health and has a really complex caseload where just using like a basic CBT for anxiety model is maybe not effective. There are a lot of complexities to consider. There are a lot of competing demands. And so there are just a lot of differences, both in terms of the practicalities and in terms of what is the training that already exists. So doctoral students are in the process of training. Their program has a certain background. Therapists, school personnel, lay people probably have another reason for using the approaches they're using. And so this is also, there may be like a de-implementation aspect of that as well. And there's also the question of the practicalities of the setting they're in, the organization they're in. So I think I'm happy to talk in more detail if there's specific follow-up questions, but I think that those are just some of the things to consider. And this is why Emily and I have been thinking too about master's level programs where there's a lot more variability in whether evidence-based interventions are taught. Can we partner with programs, for example, to teach things like exposure during graduate training?
This person's also asking where are the tarantula pictures?
I have many tarantula pictures. I had to go through a whole tarantula handling training prior to this. There's a whole backstory of that I won't get into, but feel free to reach out to me directly if you want lots of pictures of me holding tarantulas.
Yeah, I don't think I want that. Okay, so another question is, fear of delivering the intervention isn't something I had considered as a direct target for training. Would you recommend directly assessing fear of intervention delivery in formative interviews prior to trainings and implementation?
Yes, I will say more, but my main answer is yes. And I think this is what we've been thinking about a lot, is that the more that I've talked to clinicians, I mean, there are many reasons, and there are many things you're going to ask about in formative interviews, but the idea of, and all of you named a lot more that I hadn't thought of asking certain questions, of doing new things, is often scary. And there's often a role of that. And I think that once you normalize for therapists the fact that there is an emotional process happening for them in any kind of learning, right? I mean, anytime we learn to do something new, it's scary. And especially if you're asking somebody to do something that's new and they're not even sure about, it's probably even scarier. So I absolutely would recommend assessing this and opening the door to that question of what do you anticipate this being like for you as a clinician, to deliver this, to ask this question, to go into this setting, whatever it may be.
That is really great advice. And I could see that working for just a lot of things, like I've done communication work with physicians who don't really feel confident about their communication with patients. And so that might, it doesn't have to be in an exposure setting is what I'm saying. Exactly. It can be across a lot of things. Another question is, do you have thoughts about the active ingredients of consultation? For example, behavioral role plays versus case support discussions versus feedback on tape discussions. Your points about clinician anxiety have me thinking about how behavioral role play may also get some of these anxieties about using a new intervention.
Yes. Yeah, behavioral role plays are definitely a key thing to use during consultation for exactly the reason that you're saying. And so that is thought to be an active ingredient. There's some really interesting work that Shannon Dorsey has also done on like kind of digging into active ingredients of consultation. And that is definitely one of them. I mean, the other thing is like the Beck Initiative in Philadelphia does a lot of feedback on tape sessions. And that is another really effective way of consultation, of providing consultation. And of course it is time burdensome. And so I think that you're hitting on exactly the things and so that are key, and it's balancing those again with feasibility. When I provide consultation to community therapists, I do, which is part of my role in the STRIVE study, I do really try to integrate modeling and role plays. And there's also the piece of, like I had talked about, with adult learning theory and knowing that the best ways that people learn is applying it to the work that they're actually doing. And so I think by default with consultation, as long as you're really talking about their real life cases, you're going to be getting at that. And then the other thing is having group consultation does tend to be helpful, especially if you're doing those role plays and involving other people, even if people aren't hearing their own cases. So I would look, if you're curious in like more detail about consultation, I looked into Shannon Dorsey's work, and then Renat Bates with Julie Edmonds has another paper on that as well. But yeah.
Again, this has been really wonderful, really helping us to increase our knowledge and awareness of educational strategies. We really appreciate this. And thank you for the interactive nature of your presentation as well. Just want to say that there have been some links that have been put into the chat about where you can find the recording and the slides for this talk. Thank you to AdvanceCTR, the Department of Psychiatry and Human Behavior, and the Brown University Alcohol Research Center on HIV for sponsoring our Implementation Science Seminar Series. And next week, actually Erica's title, Dr. Erica Crable will be with us next week from UC San Diego, and her title is dissemination and implementation for substance use treatment policies. So the title has changed slightly, but we hope that you can join us for our final fall 2021 seminar. Thank you, everyone.
Thank you.